Hello. Today's lesson is going to be chapters 13 and 14. I've combined both labor and birth and nursing management during labor and birth. When we're looking at what a labor nurse actually does, there are several roles that we fulfill. One of them is the medical side, looking at our assessment of the laboring woman and determining whether it's time for her to be in our unit or not. So we have an admission assessment, and then we have ongoing assessments. And we have two patients. When we are looking at our moms, we're always looking at our mothers and our babies. And then our next role really is to educate these moms. We are going to educate them about the process of the facility that we work in, the process of labor and delivery, and then ongoing education to their specific needs at whatever point they are in their labor process. Our role is to provide comfort measures, and non-pharmacological comfort measures are first and foremost defense. And this is something that I think, my opinion is that we lack the education. You certainly don't have time in an 8 or a 16-week course to learn everything you need to know about labor and delivery in order to pass the NCLEX and learn about comfort measures. So comfort measures for nursing students, we're going to just touch on that subject, but this is really something that you would dive deeper into if you were going to be going into this specialty. We are going to touch on the pharmacological comfort measures that are available to us as nurses. Emotional support, that's emotional support for everyone involved in that birth. Intervention, early recognition of a problem is probably one of our key factors. We are, as labor nurses, we are always tasked with looking for the problem, expecting the problem, and early intervention, because that may prevent a bigger issue later. Advocating for what the patient wants, advocating for what is best for the patient, and again, that's going to be determined usually by what she wants. Being the eyes and ears of the physician or the midwife. The provider, whoever it may be, is not going to be at the bedside. The nurse is. So we are the eyes and ears. We are letting them know the progress. We are letting them know the specific situation for this patient. And then, of course, support for partner and the other family. And going back to advocacy for just a minute, this is where our comfort measures and our really understanding the physiology of birth comes into play for labor and delivery nurse. In the recent last few years, there's kind of been a wave of information out there about supporting vaginal delivery and allowing physiological birth to happen. And the nurse is integral in that process. If you have a great labor and delivery nurse, she or he may actually prevent you from having a C-section based on their knowledge and their ability to get you into the correct positions and really support the process of vaginal delivery. We'll talk more about that as we go through this lecture. The other thing I want to say is as that support, we really have to be open to what it is the mother is looking for. It's never going to be based on what our desires are. It's based on what their desires are. So women have asked me for my entire career, what was your birth like? And what did you do? And did you do this? And did you do that? And I always tell them, it doesn't matter what I did. What is important is what you want and what's happening with your process. So we never compare our own deliveries, and we never give them that as the goal. Their goal should be what they're looking for. And hopefully our moms have had some prenatal education that will help them decide what it is that they're looking for. Okay, so what causes labor to actually start? There's some ideas. We don't know exactly. We know that there are some factors that play into it. One of those is the uterus starts to stretch. And as it gets to a certain point, the body says, well, that's about all we can handle, and we should probably get this get this fetus out, which makes sense if you think about twins that come a little bit earlier. They typically the uterus will get to a larger space, though, they'll fill the uterus sooner than singleton would. So that makes sense. There's the progesterone withdrawal, which starts to happen as the placenta starts to get a little bit older. We have increased oxytocin sensitivity as the gestational weeks increase, as we get closer to the time of delivery. There's an increase in the uterus. The receptor sites are more sensitive to that natural oxytocin. That's why contractions feel different. One of the reasons contractions feel different later in the gestation. And then there's an increased release of prostaglandins as that uterus starts to stretch, the cervix, the bottom part of the uterus starts to stretch and thin and pull. There's some prostaglandin release, and all of these things combined will help that process of labor begin. This takes several weeks to get what we sometimes call it the cervix being ripened. This takes several weeks for it to happen. So when we are bringing a woman in for induction, we're asking her body to do something in a day or two that she normally would have done over several weeks. So we have to keep that in mind for the time frames. The other thing we know is that baby is releasing some hormones that are letting the body know it's time. This is just a visual interpretation of what I just said. And so there's multiple factors that go into labor. There's, they think that labor, the actual process of labor, there's some idea that those hormones that are circulating are good for the baby. We know that they cause the baby a little bit of stress, which is important for it to be able to do all the things it needs to do once it comes out. So not too much stress, but a little bit of stress is a good thing. So signs that labor is coming. This doesn't mean it's going to happen that day, but signs that it's coming is the cervix starts to soften, as I mentioned. That's that bottom part of the uterus. There might be a little bit of dilation, especially if the woman has had a baby before. You might start to see some of that cervical dilation happening. And then we have a term where the baby starts to settle down into the pelvis. The layman's term is the baby's dropped, but it's called lightening. Sometimes you'll see an increased energy level in the mom. She'll start nesting and really wanting to get everything ready and wash all the baby clothes and paint the room. And, they come up with all kinds of things. There might be a little bit of bloody show. That's that mucousy membrane, that covering that's kind of covering the opening of the cervix. Even though we call the cervix closed, it's never completely closed. There's the body kind of creates a little mucus to cover that spot. And sometimes that will be accompanied with a little bit of bloody show. It's not necessary for us to see that. We don't have to confirm that's what it is. And that may happen over a couple of weeks' time. It doesn't have to happen all at once. We'll start seeing more of those Braxton Hicks contractions. Braxton Hicks are the ones that are those pre-contractions that are getting that cervix ready for labor. And then sometimes we have a spontaneous rupture of membranes. And I talked about this in another video. If that happens, if the membranes are ruptured, we have a couple of ways of determining if it's actually fluid coming out. NCLEX likes to talk about nitrazine and ferning, which are both old methods. Now we use tools like ROM Plus or Amnisure. These are some tools that we can test to see if it is actually amniotic fluid. There's no way for us to know over the phone. There isn't anything specific that we can tell. They must come in to have that determined. And the reason why we would want to know if the water has broken is because we're kind of looking at a timeline. Not that the baby has to be delivered, but if there's been more than 18 or 24 hours since the water has broken and we don't have labor, we might consider, depending on the situation, we might consider helping that along with some medication and or using some prophylactic antibiotics to decrease the chance of infection. And determining if she's group B strep positive or not, that little swab down below that they check sometime between 35 and 37 weeks to see if mom is colonized with group B strep. If that has happened, if it's positive, then we certainly want to get some antibiotics on board to decrease the chance of infection. And as nurses, we need to be on the lookout for signs of infection. In temperature, we're usually, depending on your policy, your facility, you're going to be checking that temperature every 2 hours. Nothing in the vagina, no baths. When we're doing decreased vaginal exams, if we're looking for dilation, and looking at that cervical exam, and we're looking for the pulse rate to rise, increase respiratory rate, potentially even increase white blood cell count, which does increase slightly during labor, but it would increase more significantly if there was a sign of infection. So true labor versus false labor, I actually don't like the term false labor. It's all practice. It's all getting ready. But this is what your text refers to it. So one of the things that we're looking at when a woman comes in is what is her contraction pattern doing? That helps us determine where she is for the most part in her labor process. And we're going to talk more about the phases of labor in just a minute. But when we are looking at a contraction, we are timing from the beginning of one to the beginning of the next one, and we call that frequency. And then if we're timing from the beginning of one contraction to the end of that contraction, we call that duration. So timing of contractions is kind of important, because if you're looking at the frequency, beginning of one to the beginning of the next one, that can help to pretty much determine where she is in the phases of labor. The other thing is, when we're looking at this on a fetal monitor, we cannot tell how strong these contractions are. We actually must put our hand on this woman and do an assessment and determine how what the strength of those contractions are. And we just lightly place our hand on the top of the uterus. So one of the things that we're assessing when a mom comes in is timing of contractions, the strength of contractions, what the discomfort is for the woman, how they've changed. Have they gotten closer together, stronger in the last few hours? Are they just mild and they just are coming every 15 or 20 minutes? And then should she really be in the hospital at that point? And this is going to be determined based on your geographical area. But what we know, one of the key factors we know, is that for a low-risk woman, if we bring her into the hospital in that early phase of labor, we are increasing her chance of a cesarean section, just from that mere fact of bringing her in early. Women need to do early labor outside of the facility. Again, this is for low-risk women, moms and babies that don't have any specific risk factors, but early labor is best done outside of the facility. She can rest when she wants, she can eat when she wants, she can walk around when she wants, and she's not hindered by being in bed. Early labor is that part where moms really need to be utilizing movement to help the baby get into the best possible position for delivery. So we're going to be talking about the P's of labor: passageway, passenger, powers, position, psychological response. There's some more P's coming up. Philosophy, partners, patience, preparation, and pain control. So let's go back to this one for just a minute. When we're talking about passageway, we're talking about the birth canal, the pelvis, the soft tissues. Obviously, the passenger is the fetus and the placenta. The powers are the contraction. The position is for maternal. We have so much information about the importance of the different positions that mom gets into in order to allow this baby to navigate that passageway. This has really been not a discovery, but certainly we've been talking about this way more than we have in the previous years. In the past 5 years, you've heard a lot. There's even specific classes that delivery nurses, myself included, that have been doing this for a very long time, that have gone and learned about position and the importance of position. Spinning Babies is the trademark name of that specific class. Psychological response, so important to the progress of labor. And after all, we are animals, and we need to be able to feel safe and supported and in a comfortable environment in order for labor to progress normally. And part of the way women feel safe is to understand what's happening, and they need to have prenatal education in order to understand what's going on. Philosophy. Are we talking about low tech? Are we talking about high touch? What does the woman need? And this will be determined based on her own personality, her own cultural beliefs, her own experiences. Women that have had abusive situations in the past have difficulty sometimes with birth and the power of birth. How supportive the partners are. And this is where either a doula, a woman that is hired to come in and support the mom, or the patient's partner, or you as the labor and delivery nurse, how supportive you are is definitely going to affect how her labor goes. Natural timing, just recognizing that every labor is different and every woman is different. We have a Friedman's curve that we've kind of based all labors on, and what we have determined in the recent years is that that was created back in a time when women were using scopolamine or what we call twilight sleep. So those times are not accurate for the modern day woman. So we shouldn't be putting women on a timer based on that Friedman's curve. And then looking at how much preparation the patient had and comfort measures and pain control. And if we're using pharmacological, that's definitely going to affect possibly the timing of that labor and delivery. So we're going to go to passageway first and talk about the pelvis. I used to not spend much time here, but this is so important to understand. The true pelvis is actually the opening down below. So babies, almost all babies will fit up here in the top of the pelvis, but whether they come down this section, the true pelvis, is really to be determined. And we don't know if a woman's pelvis is going to be adequate until she's actually delivered a baby. So you have the inlet, the mid pelvis, and the outlet. And there is no way of determining, like I said, that outlet. There used to be some ideas of doing some pelvic measurements, but we don't know how much of a spread that's going to happen during delivery. So there's no true way of knowing whether there is adequate room or not. Now, there's a couple of different shapes of pelvises, 4 to be exact. And gynecoid, you can see here, this gynecoid pelvis is the one that is the most favorable for vaginal delivery. Our android are typically known as our male shaped. It's not favorable. I'm not saying it won't happen. Depends on the size of the baby, but it's not favorable. Our anthropoid is usually adequate. Usually a baby can fit through here, and platypuloid is typically not adequate. So you can see the different shapes. And again, we have no idea of knowing what shape a woman has until she's actually delivered a baby. The other passageways that we'll talk about is the cervix. The cervix is the bottom part of the uterus. It thins. We call that effacement, and it opens. We call that dilation. And this is what allows the baby to come out of the uterus down through the pelvis, down through the pelvic floor muscles, through the vagina, and then out. So part of what we do when we're doing an exam is we're determining through the use of our assessment how open and how thin that cervix is. What we're finding, some recent information, is that really doesn't determine much. The process of labor has so much more to do with the position of the baby in the pelvis and how the baby is navigating down through that pelvis, which is way more important than how open the bottom of the cervix is. So if you kind of think about the uterus as it is a muscle, and what all the contractions are doing is trying to build the fundus, which is the top of the uterus, is trying to build the muscle up at the top. So it's moving that uterus around that baby, building the muscle at the top so that it can have really strong contraction, really strong compression, and basically eject the fetus. So that is the process of labor. That's the modern day way of looking at it. But when you're doing a vaginal exam, what we're looking at is we're determining how thin the cervix is and the dilation. We're also trying to determine where the baby station is, and I'll talk more about that in a minute. So when you are discussing cervical dilation, even though I just told you it doesn't really matter, when we are discussing it with our patients, sometimes if you describe it in something that's familiar to them, they can understand. So for instance, if you say you're 1 centimeter dilated or about the size of an olive, then they understand that's about how open that cervix is. Or you're 6 centimeters dilated, about the size of a kiwi, then they understand in terms of fruit. Everybody knows what size the fruit is. So it's just another way of speaking the language they understand. So again, those contractions are going to cause that uterus to build up at the top. And as that happens, this starts to thin and open, and it goes from 1 centimeter to 10 centimeters. And it goes from 0% effaced, we usually do it in percentages, to 100%, although it's about 4 centimeters total in length. So you could do it, so 2 centimeters in length would then be 50%. This is an example of a vaginal exam. You use 2 fingers in order to determine the opening, how the opening is. We're also looking at the thickness of the cervix. We're looking at the position of the baby. We're trying to determine where the baby is in the pelvis. There's a lot of, we're determining the presenting part. There's a lot of information that goes into an exam. And so again, here is another representation of doing that cervical exam, and then you would measure against a device. We have devices on the units that let us know how many centimeters our fingers are. And so you're basically teaching your fingers to see. So the passenger, there's lots of assessment criteria that we're looking at to determine how this fetus is coming through. So we're looking at the fetal skull, fetal attitude, fetal lie, fetal presentation, fetal position, fetal station, so important, and fetal engagement. So we're going to talk about each of those. So the baby's skull is actually made up of 4 different bones that are not fused together. This is one of the ways that we're able to get such a large brained animal through our upright pelvis. So these sutures are super important. We can feel these suture lines because they just have a covering that allows these to either overlap or to separate based on what they need to do. We call this molding, in order for this baby to get through this pelvis. So here's a very good picture of these sutures, and then these bones actually can slide on top of each other. It's called molding, in order to get this baby through the pelvis. And you may see that elongation of those bones once the baby is born. This goes away within a couple of hours, and in a week, the baby will have a perfectly round head. Over the next year to 18 months, those sutures will start to harden, and the bones will become fused together. So when we are doing an exam, we actually can determine where that baby is, what position the baby is facing, if we can feel the fontanelles. The fontanelles are the spaces in between those bones. There's a anterior fontanelle and a posterior fontanelle, and you can see they are shaped differently, and so we learn to feel which one. We know which way the baby's facing based on which fontanelle we can feel. So when we're talking about attitude, this is the relationship of the different body parts, the head and body of the fetus, to another. So this is called the attitude. Our universal attitude is flexion. This representation here is what we want. This is flexed, this is deflexed, and then we have extended, and then we even have face presentation. So you see that this baby is going to navigate that passageway much better than this baby. Typically, if we know it's a face presentation, they sometimes will opt to do a cesarean section instead of a face presentation delivery, because this is very rough on that baby's neck. But sometimes we don't know that, and they surprise us. And so face presentations can be delivered vaginally, but it's not always the first choice. We prefer them to be nice and tucked and flexed. Here's another example: complete flexion, moderate flexion, poor flexion or extension, and then full extension. And this is what it looks like as that baby is coming out. And so again, you can kind of tell based on feeling that fontanelle what the baby is doing. And then we're looking at fetal lie. This is the relationship of the long axis of the baby and the mother. So it's either longitudinal or transverse. We like longitudinal and vertex, although we can be longitudinal and breech, or we can be transverse. So breech deliveries typically will not happen vaginally anymore unless you have an older physician that's more familiar with it. Midwives will do breech deliveries more often than physicians nowadays. And it just depends on the provider, and it depends on the policy and the facility that you're at. Transverse, you can see this baby is not coming out vaginally. It's not going to navigate and come down this direction. So this baby is either going to have to be turned, a provider would do that, or it's going to need to come out through a cesarean section. There is the possibility of moving a breech baby, usually not during labor, because now this baby is kind of wedged down this direction. But before labor, if they determine that the baby is breached, there are a couple of things that they can do to try to get this baby to turn. One of them is maternal movement. In fact, the spinning babies that I mentioned has many different positions for that mother to get in to try to get this baby to turn down naturally. And then a provider sometimes will do something called an external version, where they will bring the mother in, give her a uterine relaxant, maybe terbutaline or something to that effect, and attempt to coerce by manually turning this baby. Some providers are better than others at that, and that can save her from a cesarean section if we can get that baby to turn. Other factors that we're looking at is fetal presentation. Again, we have complete flexion, which is what we like, that full extension, that poor flexion that I mentioned before. And all of this is head presentation, and then we have shoulder presentation. Here is breech, full breech, and a footling breech. So we have all different ways that this baby can try to navigate that pelvis. Obviously, if it's smaller, premature, it has more opportunity to move around in there and get into a non-optimal presentation. And then we have position. I don't expect you to memorize all these. I just sometimes will see NCLEX questions that are discussing the different options for these babies and where they are. And so I just want you to have an idea of what you might hear it talked about when you're in your clinic environment. So I just want you to have an idea of what we're discussing. So when we're looking at fetal position, we're looking at where the occiput is in relationship to the pelvis. So here, the occiput is the posterior bone. And so this left occiput anterior is saying that this baby is, the back of the head is facing towards the front anterior. This is where your medical terminology comes in. And here we have left occiput transverse. So now our occiput is facing the mother's left, and it's facing the mother's side. And you can see it goes all the way around. So what we really prefer is this baby to be facing the mother's back. We want the face to face the mother's back, so the back of the head should be towards the mother's anterior portion of the pelvis. And the reason why that's desirable is because that is the path of least resistance through this pelvis. We want this baby to be able to navigate under the brim and out the true pelvis as easily as possible. And these two positions are actually the best way for that to happen. The next thing we're looking at is fetal station. So station is the top of the baby's head in relationship to where we are in the pelvis. And when we get down to these ischial spines, we call that zero station or engaged. So everything that happens above the ischial spines is going to be a negative number, and everything that happens below the ischial spines is a positive number. So we call this baby engaged when we get to the level of 0, and as it moves past that, we have +1, +2, +3, +4. And again, this is one of the assessment criteria that we're determining when we're doing an exam, is how engaged or how far down the pelvis this baby has become. And this is just another example. Now this baby is looking straight at you. So is this our desired? Probably not. No, we want it to turn around. This baby is actually what we call occiput posterior, so that it's facing sunny side up. Sometimes you'll hear it called that way. This is not the most optimal position, but it's a good picture of the ischial spines in the station, so that's why it's in here. So I've mentioned before spinning babies, and I wanted to throw just a little bit of this information in here because as a labor and delivery nurse that's been doing this for more than 20 years, I was fascinated to learn that there was much that I didn't know. So here again, what we're thinking about in terms of labor is we think in levels. Inlet is in stations. So -2, -3, -4, we're thinking about inlet. This baby is not engaged. It is not ready to be born. Mid pelvis is in stations, -1, 0, +1. So now we're in that mid pelvis. And then our outlet is +2 and lower. Knowing what station this baby is going to help us determine what positions to put the mother in to help the baby navigate that station a little bit easier. Leopold's maneuvers, again, we did this when we were putting this mom on the monitor, but this is the provider feeling on the outside to try to determine where that baby is. And this, obviously, this baby is breech, and this will help determine where the baby is facing. And this is a skill that I do not expect a student to master. I want you to start practicing it, but you certainly won't master this until you've been working in labor and delivery for quite some time. Belly mapping is really thinking about asking the mom, where do you feel your kicks? And then us feeling, where do we feel the bulge? Where are the stronger kicks? And where are we going to feel the heartbeat? This is a way of knowing where this baby is in the pelvis. And we're following clues for those that aren't very adept at using Leopold's, or for the fluffier moms that it's very difficult to feel, or if you have multiples, this will help determine where that baby is in that pelvis. And this is just a picture to let you know all the different movements that this baby has to get through in order to be born. There are actually 8 different cardinal movements of birth. I don't expect you to memorize them. I just want you to see that from being all tucked up, cozy in here, there are quite a few things that have to happen in order for this baby to navigate that pelvis. And this is where a good labor and delivery nurse may mean the difference between a vaginal birth and a cesarean birth, is helping this baby navigate using maternal positioning, using gravity, using the mechanics of physiological birth to help this baby navigate. Next, we're going to be discussing the powers, and I mentioned this briefly already, but this is our uterine contractions, and this is an intra-abdominal pressure that will allow this baby to get into the optimal positioning for birth, and it will allow this mother to push this baby out once it is in the optimal position for birth. So a lot of things can affect these powers. If a mother is exhausted, her uterus is a muscle, it's not going to work as well. If she's dehydrated, it's not going to work as well. If we've been using a uterotonic, something that makes that uterus contract for many hours, it's going to fill those receptor sites and it's not going to be as effective. We actually, if we use Pitocin, which is the synthetic form of the natural hormone oxytocin, if we use that for many, many hours, we've now increased her chance of hemorrhage because those receptor sites are full and that uterus is not going to be able to function to its full capacity. Gravity assists in using the uterine contractions to get the baby into a most optimal position. So the uterine contractions, again, the whole idea is to build that fundus in order to create that ejection reflex. We efface, which is thinning out the cervix, and dilate, which is open the cervix. That happens from our uterine contractions and fetal positioning. And then the mother will use her pushing power to expel or eject this baby. So here is an example of putting this mom on a fetal monitor. And one of the things that we are looking at when we go on the fetal monitor is we're looking at the fetal heart rate, and we're also looking at the contractions. Once again, This external fetal monitor does not tell you how strong the contractions are. So this fetal heart rate is going to be represented here, and then our contractions will be represented here. Now you will see this number change as we see our little hills of contraction, but it is not specifically telling us the strength. This can be calibrated. It's just picking up movement outside the mother. So once we have determined that our baby is doing well and we have assessed these contractions by placing our hand on the fundus, looking at frequency, which is how often they're happening, looking at duration, how long they're lasting, feeling the strength, we need to get this mother up and moving. Laying in this position, flat on her back, continuous fetal monitoring is a sure way to increase your chance of a cesarean section. And there's been a lot of talk about that in the last few years. And I have another video that goes into fetal monitoring specifically, and where it breaks down what we're actually looking for. So I'm just briefly going to discuss it here. Again, we're looking at uterine activity. So here, this is called the tokometer. It's usually abbreviated to TOCO, and this is looking at movement in the uterus. This is an external fetal monitor. It does not tell us the strength. If we had an internal fetal monitor, which we will discuss in another video, it would tell us the strength. And we are looking at how long these are lasting and how frequently they're coming. So frequency, duration, intensity, and are we getting a good period of relaxation? Because whenever this contraction is happening, this baby is being squeezed. So we want to make sure there's a good rest period in between each one. So when we are looking at our nursing care during that first stage of labor, there's a lot of criteria that we are assessing. We're asking privacy questions. How many pregnancies have you had? Any miscarriages or abortions that I need to know about? Any babies that you delivered and maybe gave up for adoption? So obviously we're going to be asking these questions in a private scenario. We usually tell the partner we just need 5 minutes. We have to ask these questions privately by law, and then we can get you back together. And then we ask any sexually transmitted diseases, any history of psychological problems, any drug use, smoking, alcohol with the pregnancy. And this is a great time to ask those domestic violence questions. Any history of domestic violence, history of suicide attempts, all those things that you will get a better answer if you ask privately. This is when you're going to do it. And then we're going to be looking at our admission history. What do we need to know about this pregnancy? Has she had any issues? Did she have any problems before she got pregnant? We're going to be looking at her laboratory tests and any other special tests that she had done, any ultrasounds, her diabetic testing, if she's had blood pressure issues. We're going to be asking what her childbirth education was and what her birth plan is now, and then we will complete a full physical assessment. Really deciding whether she's going to stay or go is an important aspect of being a labor and delivery triage nurse. Determining does she really meet the criteria to need to be in the hospital at this point? So this is a back to basics protocol that I created as part of my DMP project of reducing cesarean sections, and it was based on the CMQCC toolkit. So encouraging childbirth education, every woman that we come in contact with, we need to encourage them to get some sort of education, whether it be going online, whether it be part of a hospital class, whether it be a private class, whatever it is she needs to do to get some, reading a book, looking at websites. There are some really great websites out there. Lamaze.com is one of them. Giving her a list of classes in your area before she leaves triage. Even someone that's going to deliver in the next day or two could still use some more information. And the reason for that is knowledge is power. And then looking at early labor. Early labor is considered, we now know, early labor is really up to 6 centimeters. And I know when we look at those phases of labor, it might be determined a little bit differently in our textbooks, but the evidence is telling us that we really don't start seeing an active labor pattern for most women until they reach about 6 centimeters dilation. So are regular uterine contractions present? Are they happening every 3 to 5 minutes? Are they at least a minute long? Can the patient walk or talk through them? Have they become more regular and more intense over the past few hours or so? If they're still what we consider early labor with no medical needs, best practice is to send them back home. I know women don't like to be told that that they're not ready to come, but honestly, we're doing them a favor. Offer them comfort measures, give them realistic expectations, and send them on their merry way with some good education about when to come back. You're actually doing them a favor. So when we are doing our assessment in that first stage of labor, we do the admission assessment, like I just said. We do the full physical assessment, body systems, vital signs, heart, lung sounds, height and weight. We can ask them their height and weight. They know it. It's been done every time they go to the doctor's office. We want to do a fundal height measurement at that point to determine if our uterus measurement in centimeters is actually about the same as our gestational age. It's kind of a down and quick little assessment we can do to determine if there's any major problems. So for instance, if you were doing a fundal height and you were measuring from the xiphoid process down to the top of the symphysis pubis, and your patient is 39 weeks and you only got 34 weeks, we might start thinking, is she not as long as she thinks, or do we have some sort of intrauterine growth restriction going on? So it gives us a quick assessment so that we can continue looking for problems, because remember, that's our job, is we're looking for problems for early intervention. And then we're going to look at our uterine activity, including contraction frequency, duration, and intensity. What's the status of her membranes? Is it intact, or has it ruptured? And if it's ruptured, we want to think about TACO, time, amount, color, odor. These are our assessment criteria. Cervical dilation and degree of effacement. We're going to have to do an exam to determine that. It's always good to ask what her last cervical exam was in her doctor's office to try to determine if there's been much change. Because if she was 4 centimeters in the doctor's office and she's still 4 centimeters, then she hasn't made much change. If she has any vaginal bleeding, we do not do, let me rephrase that. If she has significant vaginal bleeding and we are unsure of where her placenta might be, we do not do a vaginal exam, because you don't want to risk the chance for having a placenta previa and potentially putting your fingers through that placenta. That would be very detrimental to both mom and baby. We're also looking at fetal heart rate. We're looking at position. We're going to determine that through Leopold's. Station, we're going to determine that through our vaginal exam. And then how well is she coping with what's her pain level, and how is she coping? We're also going to look at her prenatal records. Does she have any medical history that we need to know? We're going to look at her hepatitis status, rubella status, group B strep status, HIV status. I'm going to cover our prenatal labs in another video. I'm just going to briefly discuss these here. But when they come in for delivery and it's determined that they are going to stay, so this is in their admission process, we're usually are going to do a routine urinalysis. We're looking for lots of things in that urinalysis, specifically protein. We're looking at our CBC, because we want to know a baseline hematocrit and hemoglobin. And then most facilities have a hold clot. So if we need to do a type and screen or something more, we have a hold clot available to us. And then depending on where you live, you may be doing a 3rd trimester syphilis screening and possible drug screening. If you live in a high risk area, you will do an additional syphilis screening on the day of delivery. So this is during their admission, you will have that completed. Additionally, during our first stage of admission, we're going to be looking at their risk assessments. Does she have a history of bleeding or any conditions that are going to put her at a higher bleeding risk? If that's true, we need to be prepared for that. We would do things like or ask our provider to have a discussion about blood transfusions and possibly even have her sign a consent, have a type and screen done, or if she's at high risk, even have blood typed for her and ready. Is she a shoulder dystocia risk? A shoulder dystocia is when that baby doesn't fit through that pelvis, and there are certain conditions, we will discuss them at a later point, that increase her chance for having a shoulder dystocia. And does she have any signs of preeclampsia? Preeclampsia can happen all the way up until 2 to 3 weeks after delivery. So we are going to be looking at the criteria to do those risk assessments. And we will talk more about that in another video. So factors that influence our positive birth experience, I can't say enough how important the nurse is in this aspect, but clear information about what's going on, about the process, about any procedures that are being done. Remember, we've been hired by this woman to support her during this experience. It is not our way, it's her way. And I think there's a good shift happening in our society right now. Women are saying, wait, this is my birth, and I want to do things based on evidence, not just because it's convenient for the provider or for the hospital. So as we're taking care of these patients, we need to keep that foremost in our mind at all times. It's their way, and they have a right to make decisions about this experience. Other factors that will affect how her birth experience goes is what support she has, not being alone. And again, that means for some people hiring a doula, or asking a family friend that is well versed in support measures coming and being part of that experience, in addition to the partner and the nurse. The sense of mastery and self-confidence. There's a lot of women that feel that birth is a rite of passage. And I see questions sometimes from students and others, why is it so important for this woman to have her baby without any intervention? It's because she's decided that's important to her, and we need to be able to support that. For some women, it's very important for them to be able to achieve it. It's like climbing Mount Everest. But others, they don't care about using intervention or using pharmacological methods. Whatever it is that the woman decides is important is what we need to support. How much trust she has in the staff caring for her. If she's excited about this pregnancy, if she has personal control over her breathing and is able to relax. This is a skill that needs to be practiced, whether you're pregnant or not, it needs to be practiced. And so being able to be in the moment and have that control over the breathing and your reactions to the experiences, the sensations that you're feeling, are very important. There's an entire childbirth education method called Hypnobabies that teaches you personal hypnosis that you practice all the months up until you have the baby. And these women are just incredible during childbirth. And then the preparation, how prepared they've been. So let's think for a minute, what does society tell us about childbirth? Most of us, unless you're a nursing student or you've had family members that have had babies, most of us are not invited to delivery rooms anymore. It's not something that even as women is a commonplace event. So where do we learn about birth? Do we hear our mothers talking about it? Do we hear other women in our circles talking about it? What do we hear them talk about? We hear them mostly talk about their negative experiences, not necessarily their amazing experiences. And then what do we see on the media? Media is, it's the shock value, it's the screaming, it's the pain, it's the torture. I'm so mad at you. Why did you do this to me? And so that's kind of been the media influence. And for some people, that's the only influence they've had. So I'm sure you've seen these pictures before. These are all from current movies. Maybe not current, but they are of your generation. These are all experiences. This is how it's portrayed. I've been to thousands of births, and I can tell you it very rarely looks like this. Most often it looks like this, and I have a series of pictures coming up. And once again, most of my videos are not appropriate for young children, unless of course you want them to have the influence and have the experience from something other than what they see on the media. Birth can look like this: calm, together. They're not angry with each other. It can look like this: powerful, relaxing, serene. It can look like this: overjoyed, again, powerful. Don't mistake power and triumph and victory for pain. Those two things are very different. It can look like this. This is a cesarean section. Remember, that's still her birth. The overwhelming experience of succeeding. It can be surprising. It can be joyful. And then this is one of the pictures of the year from a couple of years ago. And it's a birth of a family. This is an experience that this little one will never forget. Okay, so we're going to talk about the physiological response to labor. We'll shift gears just a little bit. When a woman is in labor, you're going to see increased heart rate. This is why the ranges for signs of infection and for some of our assessment criteria changes in labor. You've heard me say before, and I'll say again, everything's different with pregnant women. Lab values are different. Vital signs are different. Assessment criteria for specific things are different. Our nursing diagnoses are different. Our nursing interventions are different. So everything's different for pregnant women. We see increased cardiac output, and sometimes blood pressure can be increased during contractions. And it may not be related to a preeclamptic event. It may just be because she's in pain, or because that uterus is contracting, and it can actually increase the pressure of increase her blood pressure during that contraction. So we try to take vital signs when she's not having a contraction. We see an increased white blood cell count. That's a normal process of labor. So if we're looking for signs of infection, usually more than 12,000 or 15,000 would be a sign of infection. We have an increased respiratory rate. It's not uncommon to see a respiratory rate of 24. She's huffing and puffing and breathing through those contractions. And an increased oxygen consumption. Those are normal during labor. Decreased gastric motility. This is why a lot of women vomit during labor, because the body says, we don't have time to digest this food right now, and just lets it all go. So most women in active labor are not going to want a full meal. They do need some nutrition and some calories and some sort of carbohydrates for energy, but they certainly don't want a full meal. So decreased gastric emptying as well. A slight temperature elevation, that's a normal process. She's, after all, running a marathon. Her muscles are creating energy, and that temperature will rise just slightly. So anything over 100.4, we consider a temperature, and we need to investigate what's going on. She might have increased muscle aches and cramps. Her body is working very hard, and there are a lot of muscles that surround the uterus and surround the pelvic floor that she isn't used to using in this way. So she might have increased sensation that she's not used to. And then there will be decreased blood glucose levels, because she is using that energy for this marathon that she is running. So some of the things that we look at for women is our maternal early warning criteria. And this will tell us what we should be putting us on alert. So if we have a systolic blood pressure less than 90 or more than 160, we need to figure out what's going on. Did we just take that blood pressure during a contraction? Was this a one-off? Was the cuff not appropriate sized? Is it not in the right position? Or did she sustain this more than twice over 15 minutes? We need to be determining what's going on. A diastolic blood pressure, the policy of the facility I work at is anything over 90, we're starting to pay attention to, and anything over 110, we're going to be treating. But they kind of hit the middle of the road here and said anything over 100 needs to be looked at. Our heart rate, if we have a heart rate less than 50 or more than 120, we need to be determining what's going on. So each facility is going to decide what their ranges are in order to be alert ranges. So for instance, the facility I work at, anything over 110 is considered a potential sign of infection. Respiratory rate, less than 10, we got to figure out what's going on. More than 30, we need to determine if that's due to infection or is she hyperventilating, what's going on. Oxygen saturation, less than 95%. Less than 35 mLs of urine per hour for more than 2 hours is considered oliguria, and we need to determine why her kidneys are not producing. If she's agitated, confused, or unresponsive, and women with preeclampsia are reporting a headache that doesn't go away or shortness of breath. Both of these could be worsening signs. So this is some of our maternal early warning signs that we need to be paying attention to. Our fetal physiologic responses to labor are, we're going to see some changes in their heart rate. They're going to have some accelerations and sometimes some decelerations. And we're going to discuss more of that when we talk about our fetal heart rate video. But for now, we're just going to slightly cover it. I'm just going to briefly cover what we're discussing. There is a decrease in circulation and perfusion to these babies. They don't sat 100% in the uterus anyway, but as they're going through this process, when this uterus is causing deep contractions, that puts pressure on the placenta and constricts it some. So this little bit of stress, like I said, is good for these babies, but not too much. We don't want to make it so much stress that they are deprived of oxygen. They have increased in their arterial carbon dioxide pressure. That's normal. They have a decrease in their fetal breathing movement. That's normal. And then they have a decrease in their fetal oxygen pressure and in their partial pressure of oxygen. All of this is a normal response to labor. The way we determine how a baby is doing on the inside is, again, looking at that fetal monitor. So we know we have a normal range, 110 to 160. That's our normal fetal heart rate range. If we go outside of that, we need to try to determine what's going on. The other thing that we're looking at, in addition to the range of the heart rate, is the variability of that beat-to-beat change. How much of a change do we see in that heart rate? Variability is very important, and we will be discussing variability in the fetal monitoring video. We also talk about accelerations and decelerations below that range of the heart rate. All of those will help us determine how well the fetus is tolerating what's happening in the uterus. So we have some terminology. We call this the NICHD terminology, and this is so we're all talking about the same thing in the same way, so we can understand each other. So when you call a physician and you're talking about how, or a midwife, and you're talking about how the fetal heart rate is, instead of saying, well, the fetal heart rate's good, we say the fetal heart rate's category 1. So then we know what exactly we're talking about. We're all talking the same language. So category 1 is the desired category, and you have to meet all of these criteria in order to be category 1. Category 2 is caution. We need more information. We're not sure how the baby's doing. It could be good. It could be trending towards not so good. So category 2 tells me that we need to continue our observations. Category 3 is there needs to be immediate intervention to move out of category 3 or to expedite delivery. So when you are determining categories for fetal heart rate, you are going to be looking at these criteria. And again, I will be discussing these at a later date. So our categories, all of this information I'm talking about fetal monitoring, I'm just giving the student a basic idea of what's happening here. This is an actual certification that all labor and delivery nurses do need to obtain in order to function. If you determine that labor and delivery is a specialty that you'll be going into, you will learn this in a special class that you will become certified and then have to keep that certification up once you are working in that field. So we discuss fetal heart rate by thinking reassuring versus non-reassuring. And again, this will help us determine what category we're going into. So a reassuring pattern tells me I have a stable heart rate. It's within that normal range, 110 to 160. I have moderate variability. That's what we want. I have accelerations that tells us that our baby's well oxygenated. And I have uterine contractions that are not happening more often than every 2 minutes, and they're not lasting more than 90 seconds or so. this tells me I have a reassuring pattern and I don't need to be concerned. If I have a non-reassuring pattern, tachycardia, bradycardia, decreased or absent variability, late decelerations, reoccurrent variable decelerations, all of these things tell me I'm non-reassuring and I'm moving into that category 2 or 3. Non-reassuring fetal heart tones means a hypoxia. The baby is not getting enough oxygen. So we have to suspect that if we have a non-reassuring fetal heart rate or something else that's going on in the uterus that's non-reassuring. So when you're talking about fetal heart rate and non-reassuring, you're thinking hypoxia, not enough blood, not enough oxygen. And if we go very long with the not enough oxygen, we're going to have irreversible damage. This is why it's so important that we have interventions. Now, to continue our process here of talking about labor and delivery and the nurse's role, we're going to move into the stages of labor. So we have 3 different stages of labor, and in the first stage of labor, there are some phases. So the first stage of labor is cervical dilation to 10 centimeters. The second stage of labor is from 10 centimeters of cervical dilation to the birth of the baby. And then the third stage of labor is the birth of the placenta, and the fourth stage of labor is recovery. So let's spend a few minutes talking about this first stage of labor. This is the longest of all. There are 3 phases within it. We'll discuss that more in a minute. If you are a nulliparous, never having had a baby before, versus a multiparous, so nulliparous or primey, you'll hear that term, the primey, versus a multip or multiparous, it's going to determine the length. So some women that have never had a baby before have a very fast first labor. Women that have had babies before typically speed their labors up. And then there are specific maternal behaviors that can influence that first stage of labor. So when we are talking about first stage, again, this is the dilation of that cervix and the baby moving into position for delivery. We have what we call the early phase. That's the very beginning part of labor. This lasts sometimes as much as 12 to 14 hours for a first-time mom. Then we have the active phase, and we typically see about a centimeter every hour and a half or so of change. This active phase is when women are really having to concentrate and work with their labor. And then transition is the very end of that section that is the most intense, but typically doesn't last very long. So according to the book, our textbook, which was written in 2017, the most recent update was in 2017, we are going to call latent or early labor 0 to 3 centimeters of cervical dilation. Active labor is 4 to 7 centimeters of cervical dilation, and transition is 8 to 10. This is information that's based on that Friedman's curve that I discussed earlier. So we know, evidence tells us right now that really active labor, where those contractions really start getting closer together and stronger, is we don't see most women move into an active pattern until about 6 centimeters. For testing purposes, for NCLEX, we are going to use the numbers that are in front of you. But I tell you, stage 1, this early phase, this is when this mom is really not having to think too much about this labor. It's the active phase that they have to work a little harder, and then transition, which lasts the shortest but is the most intense. So here are several different evidence studies that you can go to that talk about the Friedman curve, that talk about 6 is the new, 6 is the new 4. Let me try that again. 4 is the new 6. Anyway, what it's trying to say is 6 centimeters is really when we see women go into active labor. So sometimes it's been in certain student comments when I've taught this previously, they make comments like, well, we just should stick with the book. The problem is a book that was last updated in 2017, that's 3 years ago, one of the best on the market. It's one of the ones that I agree with the most. Things are going to change. Evidence is always coming to light that tells us that there is new information out there. So as a prudent labor and delivery nurse, we have to stay on top of this evidence, because it's labor and delivery nurses in general, that bring evidence to the bedside. So we need to stay on top of it and know what's going on in our specialty. No matter what specialty you choose, that is what you need to do. So evidence-based practice says active labor is really more like 6 centimeters. It's not really 4. This is when we start to see a big change in that cervical dilation. So we'll just leave it at that, and know that active labor, according to our testing purposes, we're going to say it is 4 to 7 centimeters, and we'll split that down the middle and say somewhere in that 6 centimeter range is when we see women really starting to work. Continuing on with our stages of labor, as I said before, the 3rd stage is after the birth of the baby to the placental separation and placental expulsion. So that's when the placenta comes out. And then the 4th stage is the 1 to 4 hours following delivery. This is when we're in our recovery stage. Here is the placenta. Everyone's fascinated with it. This is the maternal, the fetal side, that it has the cord which attached to the baby. And then here's the sac that the baby was living in. And here's the maternal side that is attached to the inside of the uterus. Now, as you think about this area, surface area, had now is a wound on the inside of the uterus, and the uterus has to clamp down in order to keep that woman from bleeding. So this is one of the things that we're doing after delivery, is making sure that uterus is clamping down. Signs that the placenta is getting ready to separate. NCLEX loves this question, so I'm going to throw it in here. The uterus will rise upward. The umbilical cord will lengthen a little. We never want to pull the placenta out. We want to let it come on its own. There may be a sudden trickle of blood, and then the uterus changes its shape to globular. These are all signs that the placenta is separating and starting to be released. So other factors that are going to affect labor, it's going to be the position of the baby's head. I've talked a lot about baby positioning, the size of the baby's head, the presentation, how is that baby coming down, the size and shape of the mother's pelvis, how effective those contractions are, how mother's emotional and physical state are affecting the effectiveness of those contractions, the birth partner again, the support that's being provided, and medications or anesthesia that's being administered. So I've talked about the factors that affect labor before, and I just wanted to reiterate it again. How much of this do we have control of as labor and delivery nurses? Actually, quite a bit. And then we have all kinds of factors that will influence each individual delivery. Our physiological factors, spiritual, psychosocial, cultural, and environmental. So all of these are things that we need to keep in mind. It's not just taking vital signs and doing heart tones as a labor and delivery nurse. We're trying to support the entire environment. Some of the non-pharmacological pain relief measures, and I'm just going to touch briefly on them here. Relaxation techniques, women have to be open to that. There has to be some practice beforehand. Skin stimulation, either effleurage, which is that very light sensation. Pressure, sacral pressure. When we have a baby that's in the occiput posterior or face up or sunny side up position, the back of the baby's head is putting a lot of tension on the mother's pelvis. And we see that represented as back labor. Thermal stimulation, either cold or heat. Those are both really great techniques. Positioning for the mother, diversion and distraction, breathing patterns. We have things such as TENS units, which is electrical stimulation. We have shower, water, visualization, guided meditation. There's all kinds of techniques that can be used as non-pharmacological. This is a great little visualization. This is done by Penny Simkin. This is her roadmap of labor, and she is known for her work with doulas and training of doulas, and Doulas of North America, organization that she helped to found. And so here you see the yellow brick road of labor, and sometimes you get off on the cesarean section highway, or you have the rocky back pain. So there's all kinds of just hints and tips of relaxation techniques and tools to help navigate this labor. And remember, every woman's labor is going to be different. Here is an algorithm that we use to determine if the woman is coping in labor or not. And you can blow this up just a little bit. This is easily found on the internet, but this is, these are signs that she is coping. And here are some tips and hints, things that we can do if she's continuing to cope. If she's truly not coping, there are some ideas for changing the physical environment and changing the emotional psychosocial environment. And if she continues to not be able to cope with this labor, then we need to start looking at a different plan of action. And that would be when maybe we would recommend or start looking at changing her birth plan. If she decided that she wasn't going to use any pharmacological methods, if she's continuing to not cope, then we need to maybe suggest that she do use some of our tools. So if a woman is successfully using a safe, non-pharmacological pain control technique, whatever it may be moaning, rocking, rhythm, tapping, rubbing a silky shirt, saying, I can't do it, I can't do it, I can't do it, I can't do it. And then when the contraction is over, saying, I'm perfectly happy, continuing on this way. Whatever it is that she's using, let her use it. This is her birth. This is her way. This is her navigation. And if it's important for her to do it this way, then let her do it this way. Just support her. Here is a visual representation of a woman who's coping very well and a woman who is not coping very well. This is our nonverbal communication. You can tell very easily when you walk in a room how well a woman is coping. This is the birth ball. Most units have these on them now. We know this is a great positioning tool. All these different positions are helping women get in, helping their babies get into optimal positions for delivery. Obviously, these are women that are unmedicated at this point, or using something like nitrous oxide where they're not in danger of falling. And again, the bed is the enemy, and we need to get them up and moving out of those beds if at all possible. Here are some positions using peanut balls that are fantastic for helping to move these babies into good positioning. And again, these are entire courses that you can take afterwards if you go into this area of specialty. Here's another really fantastic position. This knees out is one way, and then if you turn those knees in, that changes the shape of the pelvis. So if we're having issue getting that baby in, down through the outlet, we think about the position of these mothers' knees. Here's another example of how to use peanut balls correctly. We want to make sure that we're using the correct size, and they're measured, the centimeters are measured actually right here. This would be a 50 centimeter ball. This is a 60 centimeter ball, and this is a 40 centimeter ball. So these colors need to be blown up to those appropriate sizes. And then here's an example of using a peanut ball versus using stirrups. Sometimes you'll hear providers say, oh, I just want my patient to use the stirrup on the bed because it's easier. But if you look at what we're trying to do physiologically, we're trying to open that pelvis. And by placing the leg in the stirrup, it does not do the same thing as it does when you're placing the peanut ball. So these are really effective, inexpensive tools to utilize. Here are some breathing patterns. I would not recommend using the one that she's using. This is hyperventilation, but these different breathing patterns are sometimes need to be stated by the nurse. They need to be demonstrated by the nurse in order for the patient to use them effectively. The one I find the most effective is taking a deep breath in through the nose and a slow, deep breath out through the mouth. slow, deep breaths brings oxygen in, allows endorphins to be released, and allows that calming to happen. Most breathing patterns are used as distraction techniques during labor. How to recognize that a woman is actually using them incorrectly. If she is hyperventilating, she's going to complain of dizziness, tingling of the hands and feet, possibly cramps and muscle spasms of the hands or feet. She'll talk about having numbness around her mouth, maybe blurred vision. If she continues to hyperventilate, she's going to pass out. If that happens, you're going to support her airway, wait for that carbon dioxide to build up, and then she will have a drive to breathe again. It is very scary for the nurse to watch because they turn all shades of blue as they're waiting for that carbon dioxide to build up, but she will start breathing again. Corrective measures to fix this before she passes out: breathing slowly, especially when exhaling, so slowing that breathing way down, breathing into cupped hands, placing a moist washcloth over the mouth and nose, or holding the breath for a few seconds before exhaling. So if she's at the point where she's panicking and hyperventilating, we need to try to help her get back into control before she passes out from that. And now I'm going to briefly talk about some of the pharmacological tools that we have. We have systemic analgesia, we have regional, and we have neuraxial. So I'm going to talk about each one individually. One of the things that has been a recent improvement in the United States is the use of nitrous oxide. I put this in the pharmacological, even though it's not really pharmacological. It does need to be consented. So I recommend that women that are interested in nitrous oxide have this discussion with their provider so they can get that consent or that conversation into their medical records, so we could start this right away if it's something they want. Nitrous oxide is also known as laughing gas. There's another version of it that's used in dentistry. It's a much stronger version than what we use here in the United States, but it's referred to as gas and air in Europe, and it's been used for over 100 years there. It's amazing. Women use it. It really just takes the edge off, makes them a little more relaxed. It doesn't take the pain away. It helps them to cope a little bit better. Its biggest purpose is to relieve anxiety. The beautiful thing is we see no changes in the fetus. Everything else that we use for our mothers do go to our babies as well, and we have limitations. So we see no changes in our fetus, in our fetal heart rate, when we are using nitrous. We don't see any specific side effects. Sometimes women will complain a little bit about being dizzy, but as soon as they stop breathing the nitrous, when the contraction is over, it's out of the body within 1 to 2 minutes. We do have to use this cautiously in women with a vitamin B12 deficiency. So if they're on a vegan diet that isn't including all of their essential nutrients, so a vegan that's not eating everything that they need to be eating, as far as leafy greens and whatnot, they might have a vitamin B12 deficiency, or if they're not taking supplements, or sometimes women that have had gastric bypass will have this issue. So we need to determine if that's the situation. If they do have a documented vitamin B12 deficiency that needs supplementation, nitrous may not be a good choice for them. But this is a fantastic alternative for those women that need a little something but don't want to go to a full pharmacological method. Systemic analgesia is usually something that we give through the IV, and it's typically opioids. So you'll see Stadol, Nubain, and fentanyl used for this purpose. It depends on your provider, depends on your facility. These are fast-acting. Fentanyl being the most commonly used. It's a fast-acting medication. It gets out of the system very quickly, only lasts about an hour in the dosages that we're using. And we like that because it can cause respiratory depression in the newborn. If the baby's born shortly after administration, we can see some decreased respiration and possibly even needing intervention. So side effects to this would be sleepiness, decreased respirations, and O2 sat in the mother. So that has to be watched closely. And they can be a little dizzy, lightheaded. We don't want them getting up and walking around after a dose of fentanyl because of the risk of fall. And then in our babies, we will see decreased variability and respiratory depression if it's given too close to delivery. So we have to try to predict where they are in their labor, in that first stage of labor before we give it. We also have a maximum amount of dosages that we can give. Typically for fentanyl, it's somewhere in the range of 6 for the entire labor. Because remember, everything we're giving to mom, we're giving to baby. So we do have limitations. When we're talking about regional analgesia or anesthesia, usually we're talking about our epidural block. This is a continuous infusion, and most often it's patient controlled, and I'll spend some time talking about that in just a minute. We also have local analgesia that we can use. We can numb the skin for repairs or episiotomy, and that's usually placed by the provider just underneath the skin. The medications I see used there, lidocaine, bupivacaine, yeah, those are the ones that I usually see there. There's something called a pudendal block. We don't see this used very often, but occasionally you'll find a provider that will still use these. A pudendal is basically a local anesthesia that's given in the vagina, way up at that nerve. And sometimes they'll use it for an extensive episiotomy or even an operative vaginal birth if they're going to be using forceps or a vacuum. And then we have an intrathecal, which is a spinal, almost always used for cesarean birth, and I will discuss the difference between the two in the next slide. So when we're talking about an epidural is done by a nurse anesthetist or an anesthesiologist, and this is a procedure that's done in the room, and the nurse will assist with this procedure, assist with positioning and the preparation beforehand. So an epidural is when a over the catheter type needle is inserted into this space just outside of the spinal cord. So this is the epidural space. And then they will thread a very thin, the size of your hair catheter here, and that medication will drip continuously. It will bathe all of these nerves, and the mom will be numb from about the nipple line down, or about the waist down. It is continuous throughout labor and delivery. This is a labor epidural, not meant to be a delivery epidural. Some women say that they have decreased sensation during delivery as well, but we do still want the woman to be able to feel a little bit of pressure so that she will know where to direct her pushes and know where to and to work with her contractions. So sometimes it's very disconcerting for a woman to have felt nothing during the labor and then suddenly start to feel pressure, and she doesn't have a lot of her own natural endorphins to deal with it because we've been numbing it during this process with the epidural. So again, the epidural is right into this space. If she were going to have a spinal anesthesia, they go a little bit further with a smaller needle and just inject the medication. They don't actually put the catheter into this space because it only needs to work for a short amount of time. The C-section is a finite amount of time, so the procedure is just a little bit different. Here's an example of that catheter being placed there. Again, it's the size of a hair. Here is the positioning that needs to happen for a woman to get an epidural. Most providers do want them to do it in the sitting up method. Sometimes you will see them laying down kind of in a curled up position, but here's the nurse supporting the woman. It's very important that she drop her shoulders and really relax her back out as much as possible, because she needs to open this space in order for this needle and catheter to be placed through. They do numb the skin before this procedure, and they will, most women describe it just as a pressure sensation. One of the side effects of the epidural is it can cause vasodilation, and so then we see a decrease in blood pressure. So our nursing intervention is to do a bolus of IV fluid directly before the procedure or as the procedure is happening to counteract that effect. We have a frequent assessment after the epidural of that blood pressure to make sure that's not happening, because if we see a decrease in blood pressure for the mother, we're going to see a decrease for the baby as well in that heart rate, because they're used to getting a certain amount of blood pressure that supports their heart rate as well through that placenta. So if we have an issue, we might need to use a medication such as ephedrine to bring that blood pressure up. That causes vasoconstriction, and we will need to counteract that side effect. Obviously, a woman that has high blood pressure, we would not be using ephedrine, because we don't want any vasoconstriction in a woman that already has a problem with hypertension. The other thing that we see with epidural is now we have decreased maternal movement, which will increase fetal malpositioning. So our nursing intervention for this is frequent positioning. Every 20 to 30 minutes, using peanut balls, making sure that we are using our spinning babies positions to help this baby navigate that pelvis. So our continuing assessments during that first stage of labor is vital signs, and that will depend on what's going on and what kind of interventions we're using. If she has an epidural, we're going to be doing very frequent vital signs every 15 minutes. If she is low risk and maybe not on continuous monitoring, we might be doing vital signs every 30 minutes to an hour. It's going to depend on your policy. Our labor progress, we want to know how well the labor is going. The uterine contractions, are they effective? Is she hydrated enough? Is she nourished enough to be able to have effective uterine contractions? What's her pain level? We're doing that with every vital sign. Remember, pain is the 5th vital sign. What's her coping ability? How is the fetal heart rate? The variability, what category are we looking at? And our amniotic fluid, color, and odor. When we're in our second stage, when we're starting to push, and this can last, pushing can last as long as 3 to 4 hours for women that have epidurals, especially first-time moms. So this stage, we need to have continued assessment. Some of the signs that we're moving into the second stage is maybe her water will break if it hasn't already. She may have increased irritability and apprehension. She may be making low grunting sounds. Her body may be spontaneously pushing, and there may be an increased bloody show. And with our continued assessment, we're going to be looking again at contraction frequency, duration, intensity. Our maternal vital signs need to be watched very closely. How is our baby responding to these pushes? How's our amniotic fluid? Are we now seeing any signs of meconium? And how is our woman and our family coping? So one of the things, some of our maternal management during second stage is we're here to support our women and our partner. And then we're supporting her bearing down efforts, encouraging no pushing until there's a strong desire or until we start to see descent and rotation. Providing instructions, letting her know exactly how well and how effective her pushes are, helping her with pain relief if she needs it, really getting her in those good, effective maternal positions to enhance descent, and preparing to assist with delivery. This is our job as a labor and delivery nurse during that pushing phase, and it can be exhausting to make sure that we are supporting her. Most women will not find effective pushing by laying flat on their back with their legs up in stirrups. That's called the lithotomy position, and that's really pushing uphill. It is not going to be effective. So we can use things like what's depicted in this picture, squat bars, using the pull method, pushing on their side, using a squatting chair if that's allowed in your facility, helping us to use the bed effectively for different ways of pushing. So flat on their back, legs in stirrups, not effective, should never be used. And then our interventions for birth. We want to clean the area when birth is imminent. Obviously, we'll have the provider in the room. We'll call our birth team in. There should be 2 registered nurses that are at the bedside that are able to perform neonatal resuscitation. We may need an additional support with the NICU team if we have certain criteria. We'll talk more about that in the next video. We're watching for complications. We're documenting, we're protecting that environment, allowing this mom to have this moment, let it be her victory, the partner's victory. Remember, this is about them, not just about us and our tasks. When the baby is born, we're going to suction as necessary. We used to suction all babies, but most babies are able to clear those secretions on their own. Neonatal resuscitation, NRP, is an additional certification that you will receive if you're working in this area. We have certain criteria that we utilize to determine if a baby needs resuscitation or not. Eventually, the umbilical cord will be clamped. We now know, this is evidence-based practice, that we want to let it stop pulsing and it's called delayed cord clamping. We want to let that baby get as much of that blood volume as it can through that placenta before we clamp it. And just a note here, before it's clamped, baby is getting still support, respiratory and oxygenation and blood flow through there, so we don't have to be as stressed in making sure that the baby is doing all of those things perfectly on its own. So for instance, if it's still coughing and sputtering and maybe not breathing as well, as long as that umbilical cord has remained unclamped, it has some time to make that transition. We want to dry that baby off just a little bit, just taking some of that moisture off so that it doesn't cool off. We're going to be doing some initial APGAR scoring. I'll talk more about that in the newborn video. And then we want to make sure we get our identification on that baby. But the most important thing is to allow this mom and baby some time, skin to skin time. We'll talk more about that as we go on. And allow them to start getting to know each other. Once the placenta has, we start to see signs of placental separation, we want to examine it for intactness. Most of the time the provider will be looking at that as well. We want to support the woman if she's had any perineal trauma. ICE is a fantastic treatment that is used right away. We may be giving synthetic oxytocin as ordered in order to support the uterus clamping down. We want to provide warmth with warm blankets to both mother and baby, really explaining the importance of this time frame. We call it the golden hour, where mom and baby are getting to know each other, mom and baby are transitioning, we're moving into our recovery phase. And then we want to do a quantitative blood loss. That's one of our tools that we're using to determine if a woman has had a postpartum hemorrhage or not, is by actually measuring the blood loss. And I will discuss that in the postpartum video as well. And then our nursing management of the 4th stages, we're going to be looking at our assessment every 15 minutes. This is probably the most critical for the mother, and we will do that for a full 2 hours. We will be looking at vital signs, which include blood pressure, pulse, oxygenation, and at least a temperature. We'll look at our fundus and where it is. We'll be doing our fundal assessment to make sure that it is firm and that there's not excessive bleeding. We'll be watching the perineal area for any sort of complication like excessive bruising, hematoma formation. We are going to be looking at her comfort level, her bladder status, making sure it's not getting too full. We're going to be performing these fundal checks and watching all of this assessment while the mother is starting to form her newborn attachment. We're also going to be watching that newborn and making sure that everything's going well with this baby. We've reached the end of this lecture. I know this was a long one. I hope you found it useful. And if you have any questions, you know where to reach me.